As far as pneumonia is concerned, the most reliable auscultatory finding on pneumonia, if I put my stethoscope on this area and I auscultate this guy, then the auscultatory finding that I'll be getting in this particular guy is bronchial breathing. Do not answer fine crepitations or like coarse crepitations. Bronchial breathing is the most reliable finding. And then like overall the most common cause of community acquired pneumonia is pneumococcus. Overall, the most common cause of community acquired pneumonia is pneumococcus, but if he specifically says which organism can cause both typical and atypical pneumonia, obviously not in a single patient, but like this organism that I'm writing before you, this can be contributing to development of not only this lobar pneumonia presentation, it could be bilateral infiltrates also. Legionella pneumophila, also called as responsible for Legionnaire's disease, is a peculiar organism that can cause either of the two manifestations. It can cause a multi-lobar pneumonia. It can cause a lobar pneumonia. It can cause only small bilateral infiltrates present. So it can be both typical and atypical. For ventilator-associated pneumonia, obviously VAP, it is going to be Pseudomonas. You will encounter a couple of questions in which Pseudomonas is not in the options. If Pseudomonas is not in the options, then your answer would be given as Acinetobacter. This was, I think, an INI-CET question which Pseudomonas was not there, so Acinetobacter would be answered. Then one of the leading cause in children with cystic fibrosis less than 10 years of age is Staph aureus. If he mentions the same patient after 10 years of age, then I will answer this as Pseudomonas. So the organism tends to change with the age and the repeated hospitalizations of a patient. Cystic fibrosis is a condition where there are a lot of mutations. The commonest one is F508 mutation, where at 508 position there's a deletion of phenylalanine, and because of this deletion of phenylalanine, the protein that is formed is defective. That protein is CFTR protein. Normally that protein has 1480 amino acids. Now if one of those amino acids is deleted, it changes the entire functioning of the cystic fibrosis transmembrane receptor, due to which the secretions will become very thick and viscid. If he says what is the investigational choice for cystic fibrosis, then investigational choice for cystic fibrosis will not be answered as sweat chloride. That is a screening test. The investigational choice for this condition would be answered as gene sequencing. Ideally, though, there is a proper set of criteria that should be used for diagnosis of cystic fibrosis, which is discussed in the pediatric section. But if they just say what is the investigational choice, then gene sequencing, representing like we should be able to demonstrate the defect in the genes, is like overall the best one. Otherwise, like it's like 24-hour. Otherwise, I can go for sweat chloride for estimation of these patients. It's a set of diagnostic criteria, guys, but single best answer for screening is why I am like dissuading you from answering sweat chloride is because sweat chloride can be having false positives as well. So, I mean, sweat chloride values could be affected by multiple parameters. Even Addison disease could be having like, chloride values getting affected. So the point is therefore gene sequencing would be supreme. Then for evaluation of any pneumonia patient, we'll be using CURB-65 score. Nowadays, they have replaced CURB-65 by CRB-65, where C would be standing for confusion. U is for blood urea nitrogen, that would be elevated. R is for respiratory rate. If respiratory rate is more than 30 per minute, that is indicating that the person is deteriorating. B would be for blood pressure values less than 90/60. And then 65 is for age of the patient if it is more than 65 years of age. If it is more than 65 years of age, for each one of these parameters, guys, for each one of these parameters, I'll be giving 1 point to the patient. Now the interpretation goes like this, that if the score of the patient is between 0 to 1, we will be giving OPD basis treatment for the patient. This 1 is incorporating only the age. Mark my words there, the 1 is incorporating only the age. Like suppose it says 70-year-old man is admitted, 70-year-old man is diagnosed with pneumonia. He is well oriented in time, space and person. 1 is normal, respiratory rate of the patient is 20, BP is 120/80, everything is okay, only age is more, I'll give OPD based treatment. But suppose I change the status and I say 60-year-old man is admitted with diagnosis of pneumonia, but respiratory rate is 36 per minute. Then I'll not keep the patient at home. Now we'll bring him to the hospital. Or I say 60-year-old man with pneumonia is having confusion. Then you'll not keep a confused man in the hospital, in the home. You'll bring him to the hospital. So if it is score of 1, excluding age, now what I'm writing is If it is 1 excluding age, that is the main point that they'll always try to ask in the question, that if that component is present of age, then it is okay. If excluding age is present, that is when excluding age any parameter. That could be like respiratory rate, blood pressure, or like confusion in a patient. If score is 2, never an issue. No, if I say 70-year-old man with diagnosis of pneumonia, respiratory rate is 36, it's a score of 2, so I'll go for IPD based treatment. But then if the score of the person is turning out to be, let me say, between 1 to 2, excluding the age, then it is gonna be still an IPD based treatment. If it is age alone a parameter, then it is OPD basis. And if the score of the patient is equal to or more than 3, then it would be ICU based care. Then it would be ICU based care that we'll be using for this patient. Now, as far as the treatment of these patients is concerned, the antibiotics that we'll be using for outpatients will be mostly oral amoxicillin. And the second antibiotic that is used along with amoxicillin would be oral azithromycin. So it's oral amoxi and oral azithromycin that is given for patients with a curve score patient, a value of 0 to 1 with age parameter of only 1 being taken into consideration. However, if the person is having any comorbidities present, if he specifically mentions like the patient is having comorbidity could be like he's having stents in his coronary arteries, he's having triple vessel disease, he had an MI previously, or he mentions previous hospitalization due to pneumonia, then I'll just modify the answer slightly. Like we will still be giving oral amoxicillin to the patient, but this time I'll be adding beta-lactam. So now the antibiotic that is being given is oral amoxicillin plus clavulanic acid. That is, I'll be using Augmentin now. That's the brand name that we commonly use. So it is clavulanic acid and plus oral azithromycin. So everything else remains the same. You can notice a slight change that came up in a question with respect to the fact that if it is comorbidities that are incorporated, then I'll be adding clavulanic acid. In ICU patient, the IV antibiotics that would be used would be as follows. The IV antibiotics that would be recommended algorithms would be like we can be using ampicillin with sulbactam. So it is not alone ampicillin, it is ampicillin with sulbactam, and along with that I can be using azithromycin. Obviously everything that I'm discussing for inpatient would be intravenous. In some MCQs you will notice that this will not be given. It would be ceftriaxone. Mark my words there. Now it is ceftriaxone with azithromycin. Ceftriaxone with vancomycin is given in empirical treatment of meningitis, but here it is ceftriaxone that would be given with azithromycin. Or we can be using respiratory fluoroquinolones, like I can mention respiratory fluoroquinolone like levofloxacin, or I can be using moxifloxacin for this patient. So if he is going to mention respiratory fluoroquinolones like levofloxacin, then I don't need combination with anything. This alone would be sufficient. So it is like or between these algorithms that I mentioned, ampicillin sulbactam with azithromycin, ceftriaxone with azithromycin, or respiratory fluoroquinolones like levoflox, or it can be moxifloxacin, or it can be gemifloxacin. Mark my words, they're not gatifloxacin. That is for gram negative. It is moxifloxacin, gemifloxacin among the respiratory fluoroquinolones for the patient. If he says what coverage would you add for staph aureus, like patient required hospitalization, like person is having a hospital acquired pneumonia, then I need to give coverage for staph aureus. Or if the culture is showing staph aureus or radiological findings on nematoceles are present, then the coverage that I'll be using in this patient would be linezolid. You are aware that daptomycin has a poor penetration into the lung tissue, so linezolid would be added. And unfortunately, my patient required intubation also. He was shifted into intensive care unit. Then I need to give coverage for Pseudomonas aeruginosa. So for Pseudomonas aeruginosa, the antibiotic that we'll be using in the patient is meropenem, or instead of meropenem, we can be using piperacillin tazobactam. So these itself are like isolated questions where he will say that the person's sputum culture turned positive. For sputum culture of the person turned positive for Pseudomonas aeruginosa on a cetrim agar, then what antibiotic would be added? So that would be piperacillin tazobactam for these patients. So what I mentioned before you is empirical antibiotic therapy, and we can then change the antibiotics depending upon the culture sensitivity report. For pneumonia, the percussion note will be dull. The air entry will be normal. This is where students make mistake. They answer air entry is reduced. No guys, air entry is normal air. The breath sounds in a case of pneumonia would be bronchial breathing, as already explained to you. And the highlight of this bronchial breathing will be, that the inspiratory-expiratory ratio will become 1:1. There will be audible gap also present between the inspiration and the expiration, and the ratio anyway changes. The tracheal shift does not happen. The tracheal shift is not there. The trachea of the patient is normal. I can just write the word tracheal position is normal in this case. But if it comes to pleural effusion, you will be having the following findings. Percussion note would be given as tonidal. The percussion note will be given as tonidal. Then for air entry, the air entry will be reduced. Along with that, he may say distant breath sounds because there's water over the lungs, so it will look as if the sound is coming from a distance, and the tracheal shift will happen to the contralateral side. For pneumothorax, already discussed hyperresonant note. Air entry in majority of cases will be absent. Breath sounds will be absent, and the tracheal shift will be contralateral. So the data has already been discussed, but then I thought I should just summarize this here for pneumonia, pleural effusion, and pneumothorax in a patient. The overall most common cause of pneumonia in AIDS patient is not pneumocystis jirovecii, guys. It is pneumococcus. It is not jirovecii. Even if CD4 count is low, even then it is pneumococcus because AIDS patient is also living in the community. Leading cause of tension pneumothorax is not penetrating trauma. It is barotrauma. The best site for insertion of wide bore needle in tension pneumothorax in adults has already been discussed. It is 5th intercostal space in the triangle of safety, that is anterior to the mid-axillary line, and tension pneumothorax in children would be the 2nd intercostal space, and this time it would be just lateral to the mid-clavicular line of the patient, just lateral to the mid, because I want to avoid the great vessel, so lateral to the mid-clavicular line. Then legionella pneumophila is always associated with SIADH. This again is a peculiarity because earlier I was teaching you that this organism can cause both typical and atypical pneumonia, but because it is associated with SIADH, so it will draw water, and the drawing of water will cause hyponatremia to occur in this patient. The sodium values in the patient will drop. Legionella can present as both of them, but if they give you a pneumonia patient in which hemoglobin is low, there is evidence of hemolysis present, then your answer again will change. Then you will say mycoplasma pneumonia. Mycoplasma pneumonia here, see, I'll write down the name of the antibody, you will get a hang of it. The antibody that I'm talking about is called as Donut-Landsteiner antibody. This Donut-Landsteiner antibody will attack self-RBCs, and therefore the destruction of RBCs by the antibody which is formed in response to this infection will explain the hemolysis and the low hemoglobin. So I said two aspects here. If you get a question on pneumonia in which hyponatremia is there, always think in terms of Legionella pneumophila. In contrast, if they give you a question in which there is hemolysis present, that's the point to be remembered. If it is SIADH, guys, it is Legionella pneumophila. If there is a evidence of hemolysis, then it is the smallest living bacteria, that is Mycoplasma pneumonia. It's a cell wall deficient organism. This is like one of the smallest bacteria that we come across, and the antibodies which are going to be present in this case are called as Donut-Landsteiner antibodies. They attack self-red blood cells, which is why this kind of a manifestation could be occurring. For Legionella pneumophila, the best test is urine. That's again a peculiarity. Don't answer culture. We can use a selective culture now, that is buffered yeast charcoal extract. We can use a selective culture media, but if they ask you to select between culture media and the best test for Legionella pneumophila, it is urinary Legionella antigen, because this condition is having SIADH, so there is a hyponatremia, and the antibiotic that would be used in this particular case, the drug of choice for management of this patient would be answered as azithromycin. In contrast, when it comes to Staph aureus nosocomial pneumonia, that is like hospital-acquired pneumonia, the radiological finding has been asked. This radiological finding will be having small cystic cavities in the lungs. These small cystic cavities would be called as pneumatoceles. Then in Klebsiella pneumoniae, obviously one hit can be alcoholic and red currant jelly sputum, but along with that red currant jelly sputum, what you can also see here would be called as the bulging fissure sign. So in Klebsiella pneumoniae, the main point to be remembered is one is the hint of alcoholic, and second is the radiological finding of bulging fissure sign. Then if he mentions a head injury patient, or instead of head injury, he says Parkinson's disease patient, Alzheimer's disease patient, or any patient in whom the airway protective reflexes are lost, then there can be micro aspiration of saliva in head injury, Parkinson, Alzheimer's disease, because the gag reflex, cough reflex is gone. So microaspiration of saliva can occur, and this microaspiration of saliva can result in development of these patients ending up with a possibility of like anaerobic lung abscess, for which the treatment would be given with help of clindamycin. I would also like to say that he may not write about Alzheimer or Parkinson. He might just say drug abuse. No, guy drank alcohol with like he took bhang and alcohol together. So cocktail of alcohol and drugs together can again result in development of this anaerobic lung abscess in a patient. Then every time he talks about a AIDS positive patient, he starts talking about pneumonia, and in the X-ray you notice bilateral infiltrates. If he says lobar pneumonia, even if he says low CD4 count, answer it as pneumococcus. But if he mentions the word bilateral infiltrates, and then in Gomori methamine stain, you can see that crushed ping pong ball appearance. That's the word to be remembered, guys. If there's a bilateral infiltrate and the Gomori methamine stain shows a crushed ping pong ball appearance, then you will say that, okay, I'm dealing with pneumocystis jirovecii, for which cotrimoxazole will be used for treatment, or instead of cotrimoxazole, you may write like trimethoprim and sulfamethoxazole. But then the point to be understood is that only if this information of bilateral infiltrates or crushed ping pong ball appearance is given, would you be answering as this. Otherwise, your answer would be given as pneumococcus.